Welcome to the Hawaii Book and Music Festival. This is the wellness panel. This panel is on the Hawaii Crisis Standards of Care, the Triage allocation framework. This Crisis Standards of Care is a specific document that we'll be talking about today. And to be sure, triage, the word triage is a word from the French battlefield. And what was learned is that there were three groups of injured soldiers on the battlefield. Those that were not badly wounded. Maybe they were bloody, but they were not badly wounded and would not suffer from a delay in care. There was another group that no matter what you did, had very little chance of survival. And the third group, the most important group, was one that if you attended to them properly and promptly, that could make the difference on the amount of suffering and whether or not they would survive. So this is really the subject today, and we're bringing this this term to play here when it comes to the current pandemic, the COVID pandemic.
So, Ara, thank you very much for the very warm welcome. So the Crisis Standards of Care document that we have, prior to this pandemic, there was not such a document that existed in the state of Hawaii. Some other states had developed documents, and the Crisis Standards of Care, and there are different forms of these across the United States, basically provide a framework or for making decisions when you run short or run out of whatever it might be. Now, you might run out, for example, out of beds. You could run out of staff. You could run out of ventilators. You could run out of certain drugs. So, part of our goal as healthcare organizations is to prepare for disasters and emergencies and make sure that we have the resources in place to the best of our ability. However, it is also a reality that cities, states, counties, islands could be overwhelmed in the event of disasters, whether it's a earthquake, a hurricane, a tornado, a tsunami, a volcano, volcanic eruption, or a pandemic. So while we can be prepared and we spend a lot of time and energy working to be prepared, it is also possible that we literally run out of resources at some point. And so the Crisis Standards of Care triage allocation framework is a framework or a mechanism for making decisions if indeed resources are in very, very short supply. Let me give you a very specific example. And this has occurred recently in places, as you mentioned, like Idaho, which has been operating under Crisis Standards of Care, and also many parts of Alaska, parts of Montana, parts of Wyoming during this pandemic, where they have literally run out of resources. And you could have a situation where you are down to your last ICU bed or intensive care bed in a hospital or a particular geographic area. And if you've got two patients that show up, and both of those patients or both of those individuals could benefit from ICU care, the question is, well, if you've only got one bed, what do you do? I mean, if you don't have any more beds, if you don't have any more monitors or all of the telemetry that goes with that ICU bed, the oxygen and everything else, the suction, what do you do? How do you make that decision? And so many places have developed a framework or a matrix that helps guide decision-making as to what to do. And that's what we did here in Hawaii last year. So as you can see on this slide, there was no document, no Crisis Standards of Care document that existed in the state. And so the hospital leadership toward the end of last summer, as we were experiencing what we thought was a significant surge, they asked the physician leadership in the state for such a document. And there was a group of physician leaders in the state that developed the document. They did a review of the available literature. They talked to a number of different individuals, medical ethicists, gerontologists, other individuals, and they had their own collective input as well. And it was a significant amount of work that this group of physicians did to compile this document based on the information that was available at the time and the best information that was available at the time. So that they developed a document called the Crisis Standards of Care Triage Allocation Framework. And that document was presented by representatives of this group of physicians to the hospital leadership. The hospital leadership looked at the document, reviewed it, and approved the document. And then that document was shared with the Department of Health and also Hawaii Emergency Management Agency. Now, it did take a matter of quite a few weeks actually for this document to be developed. It was done very thoughtfully, very deliberately. And what happened, as we know, in August and September, or actually the July-August timeframe, that we went through that peak and then our cases fortunately subsided. We did not get close to needing to actually implement the crisis standards of care. And so basically the document was shelved. It was never put into place. So even though it was developed and discussed and approved, it was never actually, fortunately, put into place. So we fast forward to this year, and as we got into the surge, and just to let folks know the pictures, the picture on the prior slide was actually a COVID patient who's on high flow oxygen in a hospital and is in a prone position. And one of the things we've found through the pandemic is that putting individuals on their stomach as opposed to on their back does help with COVID. And so that's what you're seeing. What you're seeing on this slide, the picture you're seeing on this slide, is a nurse who's come off a very long shift and literally has bruises on her face from the personal protective equipment that she's been wearing for such a long period of time. So this is, as we all know, a very, very real pandemic that has many facets and many implications. So as the pandemic surged this year, and as we started to get into July and August of this year, which is almost exactly a year after the initial surge, or the initial significant surge that we had, Department of Health posted the Crisis Standards of Care document on the website. And because it was posted on their website and it got some airplay, and individuals were looking at it, and there were some concerns that were raised about the document. So the concerns were raised by some groups representing, different groups representing seniors within the state. There was concerns represented by presented by legislators. There were other individuals that expressed concerns. So there were concerns that were expressed about certain aspects of the document. Not generally, most people accepted the fact that that crisis, having a document to guide decision-making in the event of a disaster or emergency where the systems were truly overwhelmed. Generally, most people accepted that was a good thing, but there were concerns that were raised, and these concerns in general were around three areas. One of them was the role of vaccination. There was a lot of concerns and questions about, well, you know, if I'm vaccinated and I need care, and someone who's not vaccinated also needs care, shouldn't I get priority? And so there was a lot of questions raised about that. And then there were questions raised about age, and using age specifically as an indicator or a tiebreaker in decision-making process, and also the issue of using life cycles in terms of a tiebreaker. So there were many components to this document, and many of the components were generally accepted and agreed upon, but there were at least these three specific areas that a lot of individuals had questions about or concerns about. Now, where we are right now is that because of these concerns, and there are, again, the very, very legitimate concerns that have been raised, the document is actually undergoing review right now, and actually has been undergoing review for a little while. We have asked the same set of physicians who developed the original document to re-review the document in light of where we are right now. And there are some things that we are looking at. When the document was developed last year, it was somewhat COVID-centric. But what we're looking to do is to have the crisis standards of care document be applicable to multiple events. So not just the pandemic, but if we ever were to experience, for example, if one of our islands were to experience another hurricane that was significant, or a tornado, or tsunami, or any type of natural disaster or mass casualty event. So we would like the document to be applicable in all of those different scenarios, if indeed the occasion called for it. We understand the concerns that many people have, and it's one of the things we'll be talking about today, is the concern that many people have about age and life cycles. And so there have been discussions about that and the use of age and life cycles in decision-making. And so that is being re-examined and looked at right now. And the document, when it is finished, will be posted on the Department of Health and also our website, the Healthcare Association of Hawaii. Now, in terms of timing, the document is being worked on, it is being reviewed. One of the things that is happening is that the pandemic has caused many people across the country to re-examine their own documents. There is a series of discussions being led by the National Academy of Medicine that is going on, and those series of 5 discussions, and they will not be finished till the end of November. And so the group of physicians and other individuals, because they're using input from other groups, is participating in those discussions with the National Academy of Medicine, American Academy of Medicine, the National Academy of Medicine, and they are working with them. And so they will, again, this topic has engendered a lot of discussion and interest and controversy in some areas. So we are waiting for those discussions, those series of discussions to occur. And the document will then be presented to the chief medical officers of all of our hospitals for their review. From there, it will go back to the hospital leadership, the CEOs and other leaders of our hospitals. And from there, it will go to Department of Health, back to Department of Health and HIEMA. So that's the process we're going through, and look forward to questions and discussion. Ira, thank you.
Thank you, Hilton. Thank you so much.
Thank you. Thank you. Thank you, Roger, and everyone for putting this together. It's an important discussion, and appreciate being here. And just one correction, I'm the state director of AARP Hawaii, definitely not the CEO of AARP as a whole. Just want to make sure Joanne Jenkins knows that. I'm going to share my screen right now and quickly just provide another perspective of this particular issue. AARP's concern has been on one aspect of the triage document that Hilton referred to. I hope you all can see my slides. The reason the matter came to AARP's attention is Governor Ige had issued an executive order, and in that executive order, it granted immunity to healthcare providers and facilities that should they have to make some of those most difficult decisions in rationing healthcare resources, that they would be pretty much immune from liability as long as they followed the state's standard crisis of care triage allocation framework. What became concerning was when we attempted to get a copy of this standard of care or this framework, it was very difficult, and we kind of got it through back channels in order to find out what what was contained in the standards of care, it's not that anyone didn't want to make that available, but I think the way it was looked at was the organizations that needed to have access to it did, meaning the healthcare providers. Our concern was that really the public needs to be able to know about this. So Hilton already talked about why it's important. ARP strongly supports the fact that Hawaii has a crisis standards of care, because we do think these are important frameworks to have, so that doctors, nurses, those in healthcare who have to make those difficult decisions have a framework to work from, because those are not easy decisions to make. And we recognize that no one wants to be in that position, and appreciate our medical healthcare providers and the facilities that have to do that. One of the things that we became aware of as we looked into this issue was in March of 2020, the Department of Human Services and the federal government had their Office of Civil Rights, and within their bulletin, they had already indicated at that time that age discrimination was something that they were concerned about as it relates to how coronavirus issues were going to be addressed. Similarly, which is more recent, and as Hilton indicated, that's something that they're looking at right now. As early as August 30th, the National Academy of Medicine came out with recommendations that specifically indicated that age and life cycle should not be a factor in making the decision. So from ARP's perspective, our concern is that the triage process should not include age and life cycle. Currently, it excludes race, gender, disability, and other inappropriate discriminators from the decision of what allocation or resources should be provided to people. So age should not be a consideration, and it's a concern that ARP has and continues to fight the issues of age discrimination in general. And then those who, of course, are having to make those decisions are adequately trained to ensure that they aren't involved in implicit biases. Now, Hilton also talked about the current panel reaching out to other folks, and our concern is that the panel should, in fact, include geriatricians. There were 4 pediatricians, which is fantastic. There were internal medicine doctors, but no geriatricians were on the panel. As well as the panel or the plan was reviewed by the Disabilities Council, which is fantastic. But Hawaii's State Office on Executive Office on Aging was not included in reviewing that framework, and we believe that should also be the case. And then again, the issue of transparency. We believe that the public should be aware of those crisis standards of care and be, knowing that it's in place, and that's a good thing. But so that people understand the implications for themselves and their loved ones, and are aware of what that potentially means. And so from that perspective, we really do believe that, ARP consistently is concerned about, whether we know it or not, there is bias and implicit bias with regards to age, and that age should not be consideration for any of those types of decisions. So I recognize they have difficult decisions to make, that the panels got that particular job to do. But in the end, where the state and the Department of Health, I believe, play a role, is ensuring the issue of transparency from a government perspective, but also because the governor does and has exempted these facilities through his executive order, that the state does have a bigger role in understanding and agreeing with that crisis standard of care. If they're going to say, refer to the crisis standard of care, it should comport with what the governor and the state director agree is appropriate to have in those standards of care. And so to necessarily say it's solely the responsibility of the hospitals and such, I think is a little disconcerting. Are they mostly appropriately skilled and experts in that? Absolutely. But in the end, Hawaii citizens are impacted by those decisions. And, we do want those healthcare providers to have immunity. They need to feel comfortable that they can make those decisions in those hard situations.
Thank you,
And
Kelly.
again, and again, at the same time, just don't have age or life cycle be part of the decision making.
So health security is similar to other types of security, national security, food security, information security. Health security is preparation, protection, and resilience in the face of potential health threats. So like Hilton was saying, these can be pandemics or weather or climate events. That even in the national definition, bioterror events are included. And our current state is one of health insecurity. So there was a president that was very interested in health security. You may be surprised to know it was George W. Bush. And what happened in the summer 2005, he was reading an advance copy of John Barry, who spoke here, I think about a year and a half ago. He wrote a book called The Great Influenza. This was in 2005 regarding the 1918 flu pandemic. Bush was still traumatized by 9/11 and very concerned about what other sort of events might plague the US. So he diverted Homeland Security resources and staff resources to work on legislation for pandemic preparedness. And this is a quote from George W. Bush in 2005. Even though I lived in Texas most of my life, I won't read it with a Texas accent. A pandemic is a lot like a forest fire. If caught early, it might be extinguished with limited damage. If allowed to smolder undetected, it can grow into an inferno that can spread quickly beyond our ability to control it. So in December 2006, the Pandemic and All Hazards Preparedness Act was signed into law. It was passed almost unanimously with bipartisan legislation. Everybody agreed on it. And it called for the development of a United States national health security strategy. And in 2009, this was written that included all sorts of plans and operations that identified maybe 100 potential pathogens that could be responsible for pandemic. And its goal was to galvanize efforts to minimize the health consequences associated with significant health incidents, consequences of significant health incidents. It had two goals. The second one was to strengthen and sustain health and emergency response. And the first one was building community resilience.
Well, the pandemic has had several surges. It's something unlike we've ever had to deal with before. And so it created some challenges. And I guess it felt so severe that it necessitated the discussion that went on about a crisis standard of care. Look, as an ER doc, I triage people all the time, but I never refuse care ever. And the way the crisis standard of care document was rolled out was unfortunate because we were, first of all, coming down the backside of the mountain on COVID. And also, it really terrified a lot of people, which was counterintuitive. We didn't want to do that, of course. That was counterproductive, really. And because of some of the language that was in there, as Hilton described, there's always a necessary approach to healthcare where we do decide where we can put our resources. But In this particular case, I have to say I categorically reject the way we did it in Hawaii, even though I'm Lieutenant Governor, for a couple of reasons. One, I sat through every single meeting you could possibly imagine, and we had hundreds of millions of dollars available to us to do other things, to provide more care and increase our system of care. In fact, Hilton did an excellent job bringing over 650 nurses and critical care nurses and respiratory therapists to Hawaii to make sure we didn't have to invoke crisis standards of care, which would have technically meant rationing care. So that was one thing that worked well, which we could have done in many ways. There were a lot of ways to provide extra care. So that's one challenge I had with it, that if we just invoked crisis standards of care when we reached a crisis point, it really means we didn't do our job, because this was an 18-month or 19-month pandemic. It was not something like a hurricane that took out the Honolulu Harbor, or a hurricane that took out a Maia hospital or something. So there's that. Then I have a problem with the circumstance, which is that we know the vaccines prevent the spread of COVID or prevent severe disease and hospitalization. Yet, because of misinformation, as Jerry pointed out, and Kaylee has been terrific about informing people, the scare tactics are out there. Because of that, it could be used as an excuse, because we really need to prevent the disease. We need to stop the disease from spreading before it gets to that point. And to invoke crisis standards of care and potentially refuse people care who are more likely to die because there are so many patients at that time and other younger people will survive, really gives me pause. There were just so many strategic options that we would have to actually do, as far as I'm concerned, to be considered professional in our response. So there was that. Then there were some ethical questions that I would like to raise, like, how do you prioritize care for individuals that have refused to get vaccinated? Though I will take care of everyone always. They refused to get vaccinated and spread the virus, while we had like 97% of all of our kupuna get vaccinated to prevent themselves getting sick. Yet there were circumstances, because of their high mortality rate, where with shortage of oxygen or other services, they would very possibly, just based on their mortality rate or their morbidity, get excluded from care. So there are just so many problems when there's so much resource. I just can't stand by this. So there's that. And then I also think that this is not a pure strategic question. And then I'll kind of wrap up here. This is a purely political problem now, because you've got rallies against proper prevention or preparation for healthcare response, like we're seeing in many states, like Texas, only 53% vaccinated and not beefing up their hospital systems adequately. The US is only 58% vaccinated. There's so many things that have to be done before just giving carte blanche immunity if we had to ration care. I just really had major problems with it. Finally, look, I was the chairperson of one of the three chairs in the response, and no one mentioned this to me till it rolled out to the press, which is bad, if I may, because these are some of the questions I would have raised so we didn't have this problem, which really did scare the lion's share of those seniors that would have been affected by it. So there were lots of problems. Of course, you have to have a good healthcare system, which is why we're lucky to have Hilton, and we're lucky to have our hospitals and our doctors, and we're really lucky to have advocates for our seniors. But this one was definitely a bridge too far. And the very last thing I'll say is, if the state of Hawaii has to invoke crisis standards of care when we have the second lowest mortality rate and the second lowest case count in the country, then I will say our entire country has already doomed itself to health inequities. So there's just so much work that would have to be done before we ever get here. We would be negligent if we didn't do it. So for all those reasons, I just can't support crisis standards of care as it's currently conceived. But I can support any number of ways to make sure everyone gets care.